Good morning. Today we're going to be discussing medication administration management. I'm Brittany Opshal. I'm a nurse with my BSN and I represent Eastland Memorial Hospital. I'm a quit partner for many of you. We need to talk about responsible medication administration management. Medications are meant to treat, cure, or even prevent illnesses. However, they have the potential to cause side effects or adverse events. It is important that the orders are properly followed, administration routes checked, policy and procedures understood, and attention to detail given to ensure the safety of our residents. Medication administration is an everyday part of the care that is provided to the residents in a nursing facility. Due to the potential danger of medication administration, it is imperative that the nurse understands the importance of performing the task safely. Becoming proficient in all of the aspects of medication administration will ensure that the residents are kept safe through all areas of the care provided to them. The nurse needs to understand not only the routes of medication, but the ways in which medications affect the elderly residents and their care, as well as the federal regulations that discuss medication administration. In addition, the nurse must also be able to report medication errors as required by facility policy and procedure and adequately supervise unlicensed personnel who are responsible for medication administration. Now, the role of the nurse in medication management. Prior to any administration of medication, the LVN must understand that they are personally accountable for every aspect of the administration process. Any time that the LVN feels as though he or she may not be able to perform the task effectively and safely, they must ensure that the RN or administration is aware of the issue in order to assist the LVN in obtaining the needed knowledge or training to do so safely. The B&E statement, the LVN scope of practice is dictated by the MPA and the B&E's rules and regulations. They define the legal scope of practice for LVNs is directed scope of practice and requires appropriate supervision of a registered nurse, a physician assistant, a nurse practitioner, physician, dentist, or podiatrist. It is important that you know the medical diagnosis that is being treated. If you are administering a high blood pressure medication, it is important that you know that they have high blood pressure. We need to know what kind of medications that we're giving and the side effects. Administer medications following the 10 rights. Monitor, document, and report responses to medications, treatments, and procedures. We do need to be performing those follow-ups and documenting them. Communicating and documenting responses, clarifying orders or treatments, must consult with healthcare providers when they decide not to administer a medication. It's not enough that whenever you decide not to give a medication, if a blood pressure is too low or parameters, you must document that. And if there's for some reason a regularly scheduled medication that falls outside of those parameters, you need to clarify and you need to communicate with the RN or administration or the healthcare provider why you're not giving that medication. Using evidence-based information to contribute to development of interdisciplinary policies and procedures related to a safe environment, including safe disposal. The LVN, being within the directed scope of their practice, are not allowed to delegate tasks, but they may assign specific tasks to unlicensed personnel according to their education, experience, and the knowledge to handle a task. LVNs may assign medication administration to certified med aides as long as they maintain appropriate supervision of the medication aid. And we'll discuss what those responsibilities entail. Now we will discuss assigning specific tasks to unlicensed personnel. And that's wrong right there, delegating to CMAs, because we just clarified that you may not delegate, but you may assign. LVNs may assign medication administration tasks to CMAs, ensuring proper supervision for safe and effective patient care. It is ultimately the responsibility of the LVN to ensure the CMA is practicing within their certification and administering medications safely. Checking the MAR is part of the oversight process, and the LVN needs to be aware that checking the MAR for proper administration of resident medications is imperative that you're making sure that all of those medications can be safely given by the CMA. A question that came up in one facility, an LVN asked if a CMA may administer nebulizers or respiratory medications. And the answer is no. Typically, it's no insulin, no G-tube medications, and no nebulizers. In the event that the LVN does not feel as though the CMA can effectively perform the requirements of administering medications, that information needs to be passed on to the RN who oversees the LVN's practice. Medication administration in nursing homes is a complex process that requires a collaborative effort between the CMA, LVN, and the RN to ensure safe medication administration. The LVN must understand that ultimately they are responsible for every aspect of medication administration. The administration protocol is proper administration procedures following that ensure the medications are administered following strict protocols to prevent errors or misuse. Properly document all administered controlled medications to maintain accountability and accuracy. And regularly train nursing staff on the correct administration procedures for controlled medications and review incidents and best practices. Now we will discuss the 10 rights of medication administration. First, of course, we have the right patient. We're checking the name on the prescription and wristband. Now, a lot of the times I understand that in nursing home facilities, we don't have a wristband on. So if the patient is able to, if they are alert and if they're oriented, and if they can give us their name, then we ask for their name. If they're not, then we check it against the photo that is in the MAR, whenever we're administering it. So you have to use 2 identifiers to confirm. We have to ensure that we're giving the right medication. Verify medication name and expiration date and avoid using brand names. Check the prescription and ensure antibiotics are reviewed regularly. We need to be doing that in order to make sure that we are following through with our antibiotic stewardship to reduce MDROs. We're checking the dose, confirm the appropriateness of the dose and the prescription. Calculate and double check if needed. If you question a dose, it's okay to ask somebody if that falls in a normal parameter, especially if it is a blood pressure medication, if it's a pain medication, if it's something that has the ability to really impact the resident's health and we have a concern for the dose. Or checking it against labs, especially if it's something that can be measured with lab work, such as digoxin or blood thinners. We have to make sure that we're giving it by the right route. Check prescribed method and appropriateness of the route. We need to make sure that our residents that have, are unable to swallow, if all of their medications are ordered by PO or oral route, well, we may have to give them a different way, or they may have to be crushed. We just need to make sure that we're giving it the appropriate way. The right time, verify frequency and correct administration time, confirm time of last dose given. If we do not give our medications within the prescribed amounts, that is a form of resident neglect. Right evaluation, ensure medication's efficacy, regularly review medication's effectiveness, report any adverse effects. The MAR is a legal document. Facilities are free to use any version of a MAR as long as it includes the following elements: the name, date of birth, physician's name, allergies, dates, medication information, time of administration, and a place for the initials of the individual who administers the medication. Many facilities choose to use an electric MAR in the hopes of decreasing the number of medication errors that occur in the facility, thereby ensuring a safer environment for the residents. Still, there are facilities that use paper medication administration records. No matter what type you use, it is the responsibility of the LVN to understand how to accurately document an administration of medication on the resident's MAR. Standards of nursing practice dictates the LVN's responsibility to accurately and completely report and document administration of medications and treatments. The LVN must understand all of the components of the MAR and how to use it. If the LVN or CME feels like they need additional training, they need to report that to their supervisors, RN, or administration. The MAR is crucial to the safety of the resident. as anything that isn't documented will be noted as not having been done, which could result in a double dose of medication being administered. That is one way in which medication errors can occur. Another way is when the medication is removed from the secure or locked area. The prescription label should be checked against the MAR to ensure that they match. As the medication is removed from the bubble pack, multi-dose bottle, poured liquid, the nurse should again check the prescription label against the MAR. The final check should occur at the resident's bedside just before medications are given. And these are some of the medication errors that have occurred. We'll discuss it later about the bubble packs. But once you pop the medication out of those bubble packs, they cannot be returned to that bubble pack. You cannot put the medication back in. You can't tape the back of it. You can't glue it back in there. You can't staple it. Any kind of adhesive cannot be placed over that. So it's okay if you pop the medication, if it's a pain medication and the resident doesn't want it, or if they're unavailable, or maybe they don't have any pain right now. It's okay. You just have to follow the right destruction protocol, disposal, and make sure that that's documented. It's no big deal. But we can't put it back once we've taken it out. And then we need to make sure we're giving it for the right reason. Check to ensure the resident needs the medication. So that would be something like a pain medication or an anxiety medication. If they can't have it every 8 hours or 6 hours and it's just PRN, then we don't need to be giving it if they don't need it, or if they're asleep, or if they're vital signs at that time. If we're going to give a pain medication that maybe is a narcotic and their respirations are 12 and they act disoriented when they typically don't, then maybe now isn't the time that we give another pain medication or anxiety medication that may exacerbate those symptoms more. We need to make sure we're doing the right documentation. Sign after medication is administered and ensure the medications have a start and end date. Right to refuse. Ensure you have resident or representative consent, especially for antipsychotics. But they do have the right to refuse if they have the capacity to do so. Make sure they have the right education. Ensure the resident understands the intent of the medication, and educate them to inform others if they're experiencing any untoward effects. Medication storage. This is what we were talking about with the bubble packs. When a medication is removed from the bubble pack and not given for any reason, it is not placed back in the container. It must be destroyed in the presence of 2 licensed nurses. The disposal must be documented on the line for that dose. Never use tape or any other kind of adhesive to put the pill back inside. And for inspections during narcotic count, regularly check medication bubble packs for any sign of damage or tampering during scheduled narcotic counts. Reporting and disposal, immediately report any damaged medication bubble packs to management for proper disposal and replacement. Also ensuring med carts are locked and everything is labeled. We can't leave medications out, especially, it doesn't matter what kind of medication it is. If it's a cream, we can't be leaving it unattended on top of the med carts, even if we're just running into a resident's room. There's many times that I've been in a facility that I've been walking by and a med aid has been in the resident's room and there's been creams or a pill left on top of the medication cart. Your medication cart has to be locked and those medications have to be put away, and your screen needs to be covered. Out on pass medications. This was another tag that a facility received. 2 residents had very similar last names, and they gathered all the medications for the resident to take with them, and they didn't get too far. They probably got about 30 minutes away, and then they discovered their error. They called them, and it wasn't a big deal at the time. They came back, but there was an incident that happened, and the family reported them to the state. So they did get a tag for that. So it is important that whenever we have a resident that's going out on pass, our goal is for them to be able to leave the facility safely with their medications and continue with their treatment as if they were still in the facility. So we have to gather all the medications for the resident to take, assure correct medications are sent for the correct resident. Let's not get in a rush when we're trying to send all these medications with a resident, because some of our residents take a lot of medications. Provide clear administration instructions on how to administer the medications, including right person, dose, time, and route, and frequency. A lot of our family members are not going to have medical training or medication training, so they don't understand. They're going to understand the blue pill once a day, the red pill twice a day, the yellow oval pill 3 times a day if he's hurting. So it's very important that we give detailed instructions, but yet simple and concise so that they understand. And if they're supposed to be taking their blood pressure before they give a certain medication, that we make sure that they're doing so. We need to use common language, plain language terms. So whereas, like for instance, for blood pressure, where we understand systolic and diastolic, we may need to say top number, bottom number, making sure that we're writing those numbers out. And if they have any questions or concerns, that they are calling us at the facility and asking us for clarification. We need to be, whenever they do return, we have to inventory and verify return medications. Notify management and nursing of any discrepancies. Document medications returned. Ensure the resident is unharmed if there is a medication discrepancy. When inventorying the medications, it's important to pay attention to all the medications, not just the controlled ones. There may be times where we're sending the resident out with narcotics, but it is just important that we document the blood pressure medications that we sent out and the quantity if there's any discrepancies. Of course, we want to report the narcotics are controlled, but say, for instance, if it is a blood pressure medication, let's say we sent them out with 6 blood pressure pills and they were supposed to take all 6 blood pressure pills, but they came back with 4 blood pressure pills and they didn't document blood pressures or anything. It is important that we assess that resident and make sure that the resident is unharmed, and that we notify the provider that the medications weren't given, because that could impact their ability to leave the facility in the future. And that we document that, especially if a family member that is a responsible family member comes back and they didn't administer their medications how they were supposed to. We're going to talk a little bit about pain management and how important it is for our residents and how important it is that we're administering their medications on time. Pain is defined as an unpleasant sensation that is both a sensory and emotional experience associated with an actual and or potential tissue injury. Pain can be present even when a person cannot communicate it, such as in the case of Alzheimer's or other dementia-related conditions. Assess chronic pain. Assessment and proper diagnosis of the chronic pain is going to be a little bit different than assessing the pain in someone that is acutely experiencing pain. And it will depend on accurate historical and clinical information along with the evidence that is found during an examination. When assessing for pain, the resident's perception of their pain is the most important factor and can be determined either verbally or assessing their physical symptoms. And chronic and acute pain is a common problem among nursing home residents that is often difficult to manage or is mismanaged or not managed at all. Yet uncontrolled pain or suboptimal pain management can decrease residents' quality of life and lead to worsening of other medical conditions and increase the risk of immobility, falls, and other complications. Every resident deserves appropriate pain management, and the nurse must be adequately prepared with the knowledge and the information to meet the resident's needs. Pain medication stewardship is important because of its impact on the quality of the care residents receive. The interesting thing is the opposite of the overuse of antimicrobials, antipsychotics, and pain medications are often underused in the nursing home population. There are many factors that complicate and hamper the appropriate management of pain in older adults, including a high prevalence of dementia, sensory impairment, and disability. Other issues that may exacerbate the problem are erratic staffing patterns, high turnover of nursing and administrative staff, along with the limited presence of a physician. It's important that we have a good understanding of pain so that we can enable nurses to develop an individualized plan of care for their residents who experience pain, ensuring more optimal pain management. So when we're developing that care plan for the resident, it's important that we identify the cause of pain. The plan of care should be based on an individual's preferences, knowledge of the pain location, characteristics, and causes, and knowledge of the patient's condition, prognosis, risk factors, comorbidities, and existing medication regimen. This is really a whole picture assessment. We can't just focus on if they have a wound on their right heel. We really just can't focus on that. We have to take into consideration their history, what medications they're already on. Is this resident on hospice? Establishing realistic expectations regarding pain relief is crucial. The nurse should also determine whether there are underlying causes of pain that can be alleviated without the use of medications. But the plan of care into action set a time frame for reevaluating the patient's pain management and monitor the patient for complications and side effects. It is essential to make individual resident-specific decisions when managing a resident's care. As previously noted, the nurse should first determine the cause of pain and attempt to alleviate the cause. So if it is the heels that are on the bed, it is important that we cushion the heels, that we lift the heels up, we reposition the patient, or we modify the resident's activity environment, focusing on non-pharmacological management strategies, including lifestyle interventions. Thereafter, medications can be used, starting with over-the-counter pain medications and then progressing to stronger prescription strength medications if that's needed. Throughout the process, it is imperative for the nurse to periodically reevaluate the resident's pain management to determine whether the plan needs to be revised to optimize pain management. So throughout the whole process, we are monitoring. So did the repositioning help with their hip pain? Okay, it did. Great. Let's document that. No pain noted after repositioning. Did they still experience pain after we reposition them? Okay, well, maybe we ask the physician for some Tylenol or ibuprofen, however the patient, if they're allowed to have that. So if that got rid of the pain, then that's great. That we document that. But if the pain is unrelieved after we reposition, we try OTC medications, maybe a warm or cool compress, and then that gets in. There's nothing wrong with the patient. So if they're repositioned, we need to make sure that there's nothing physically wrong with their hip or leg. Then we can progress to narcotic pain medications if all else fails. So this is what I said, beginning with the non-pharmacological treatments. Depending on the cause of pain, always attempt repositioning and cushioning problematic areas. Ensure the resident has a quiet place to relax might be helpful. Making sure the temperature of the room is comfortable. The nurse should consider recommending the use of cold packs and or warm compresses to help minimize the resident's pain. Recruiting therapy, if appropriate, and of course with an order, and encouraging the resident to participate in activities can distract them from pain. Non-pharmacological measures should be initiated and continued even when medications are necessary, as the co-commitment of these measures and pharmacotherapy can increase the efficacy of pain management. Ultimately, the nurse, or even CMA or CNA, as the resident's advocate, is responsible for ensuring that we are being collaborative in all of these treatments. In certain situations, the medications can be given in excess or underused. It's imperative that the nurse is aware of these situations as the steward of the care being provided to the residents. There are special considerations that we need to take into consideration for medication administration in the elderly. Some of the special considerations are that a lot of our residents take a lot of medications, polymedicine, so we need to understand how some of those medications interact with each other and what the side effects and adverse effects they can be on our residents. The LVN must understand that they are personally accountable, again, for every aspect of the administration process. With polymedicine, It is the increasing number of medications, 5 or more, and is related to a similarly increasing number of medical problems. Our people are living longer, so we are seeing more health problems. There are many different factors that contribute to the polymedicine and is generally seen in the elderly. These include multiple disease processes, multiple healthcare providers. Some of these residents have primary care physicians, cardiologists, pulmonologists, wound care doctors, nephrologists, kidney doctors. So a lot of them will write conflicting orders. So it is important that we're checking these orders and making sure which ones we're supposed to be giving. The nurse caring for these residents should understand the reasons behind polymedicine in order to be an advocate for the resident by identifying the polymedicine and working with the physician to remove any unnecessary medications. When we talk about adverse medication reactions with the elderly residents often have prescriptions for medications that may be more likely to cause adverse drug reactions. These reactions can be due to the age-associated physiological changes, or it can be caused by a drug-to-drug interaction. The nurse must be aware of these changes in order to ensure resident safety against issues such as falls or worsening of other medical conditions. And then we have altered medication actions. As a person ages, a number of natural physiological changes occur that alters the way the body handles medications. Age-related alterations in a drug action reflect the changes in body composition and organ function associated with the natural aging process. For many medications, age-related changes in pharmacokinetics and pharmacodynamics can be anticipated. Additional factors such as nutritional status, medication-to-medication interactions, and comorbidities with other medication or medical conditions may also contribute to the complexity of drug actions in the older patient. It is important that the nurse administering the medications to these residents understand that the resident is at risk for altered medication actions to ensure increased monitoring after their administration. That concludes the medication administration. We already spoke about some of the issues that we've seen as far as med carts unlocked, medications left on top of medication carts, computers left open, medications trying to be returned to bubble packs, the drug diversion, destruction, ensuring that the LVN has appropriate supervision. LVNs are not allowed to delegate, but they can assign tasks to CMAs. And if anyone ever feels like they are not competent to give the medications, or if they have a question about a medication, that they ask somebody. Thank you for listening to our presentation.